The hip angle is approximately 28 degrees and is flexible all of the body to the move forward. The new angle is 0 degrees, indicating that the needle is in extension as improves stability and start of the support. The angle has an angle of 0 degrees, indicating a neutral position to receive the load of the body weight and transformate it physically. Hip angle 31 degrees of flexion. The hip remains flexed to allow for snow observation and stabilization. While the foot is allowed an increase from initial constant is normal as the hip must accommodate the body for the motivation. 50 degrees of flexion, the new should begin to flex absorb shock and act as a shock absorber. This belief is adequate consideration that the increased flexion is crucial for the gain ankle angles 5 degrees of the dorsiflexion. Turning the responsibility of loading the angle moves from a neutral of simply plantarflexion position to dorsiflexion. This change helps manage around the reaction forces of stabilize the foot. Hip angle change of station is because of the hip begins to move from the flexion to extension to facilitate the forward movement of the body. And ball weight of 10 is normal in the middle pass, where the hip is near a neutral position or sleep station. Can angle 29 degrees of flexion. During the middle pass, the new is a middle flexion position. This ball weight at the can as pass a new most stabilization the body quick, allowing the smooth forward movement of the center of the mass. Ankle angle 7 degrees of the dorsiflexion. The ankle is excluded dorsiflexion, which is typical for the pass. This allows the off to support the body weight efficiently with preparing of the transition to the hold to off.
Hip is in a slight station often, which is functionally normal at the stage to propel the body forward. The king is in full station or almost neutral. This allows for an efficient transition of weight to the other foot and better transmission of force. The ankle shows plantar flexion 20 and think of eccentric concentric work. This movement is essential to generate final propulsion during the takeoff of the foot. The hip is neutral at 0. This marks the transition between the previous extension and the waning of the flexion. The cane is moderate flexion 32, which facilitates the takeoff of the foot and reduces the moment of inertia during swimming. The naked plantar flexion of the 20 indicates the work of the muscles that provide the necessary impulse for the takeoff of the foot.
Hip angle 20.6 degrees of flexion. During the initial swing, the hip moves into ready flexion to initiate forward movement of the lower limb. This angle is appropriate for this phase. The knee angle, the 60.8 degrees of flexion. A considerable angle of flexion is expected at this stage. The knee flexes to reduce the length of the lower limb and facilitate clearance on the foot from the ground. The ankle angle, 9.9 degrees of dorsiflexion. In this phase, the ankle should be dorsiflexed to allow clearance from the ground, which is currently observed there. Muscles involved include and the hip flexors, the psoas iliacus and rectus femoris to initiate forward movement, the knee flexors, the hamstrings to allow necessary flexion, and the ankle dorsiflexors, tibialis anterior and associated muscles to keep the foot clear on the ground. The mid-swing phase, the initial mid-swing, the foot of the swinging left lifts off the ground and the knee flexes to prepare the leg to the ground contact. The hip flexes to help swing the leg forward, and the final mid-swing, the foot of the swinging leg approaches the ground, and then it stands to propel the body forward. The hip stands to help propel the body forward, and the joint movements. The ankle joint, the ankle stands to advance the foot forward. The knee joint, the knee extends to propel the body forward, and the hip joint, the hip stands to help the propel the body forward. As the swinging left moves forward, the hip, knee, and ankle joints flex to prepare for the ground contract. Joint angles. Hip joint flexes approximately 30 degrees with minimal internal rotation. The knee joint foot extends. The ankle joint remains neutral. The foot maintains a neutral position with the toes slightly flexed. The arthrocinematic. The hip extension, the hip joint is a synovial ball and socket joint, allowing rotational and sliding movements in the sagittal plane around the longitudinal axis of the femur. The knee extension occurs when the lower leg moves away from the thigh. The knee joint is a synovial hinge joint permitting sliding and rotational movements in the sagittal plane with a horizontal axis throughout the femoral.
My posture is characterized by a slight anterior tilt of the pelvis, which aligns with the prominence of my posterior anterior muscle change. This is probably due to the fact that I am athletic, in constant movement, and physical exercise. As a result, my body has adapted to the demands, ensuring that my gait is not affected displays the tilt. This posture is compatible with the dynamic and functional requirements of my activity lifestyle.
Factors such as cool furniture and heavy backpack affect posture, which relates on proprioception and postural control to adapt. A postural alteration can be due to structural deficiency, inactivity, or hereditary physical, psychological, and contextual factors. And balanced posture reduces bodily stress and optimizes balances against gravity.
Apathy with anterior pelvic tilt and the anterior posterior kinet. Change in balance present on the posterior characteristics be excessive curvature in the low back, dermatologist, rounded shoulders, and the formal head and the position.
Patient present and balanced global posture characterized by hip position, round the shoulders, cervical and the lumbar hyperlordosis, thoracic kyphosis, and anterior pelvic tilt. These compensatory patterns are associated with mouse weakening, so the shortening and the biomechanic factor, which increase the risk of long-term pain and the dysphagia.
The patterns show asymmetry in the shoulder, iliac crest, gluten fold, and popliteal fold, along with scapular alliteration and the spinal deviance. Dense findings suggest pelvic or spinal rotation muscular imbalance, and dysfunction in the pelvis and lower limbs, indicating a complex postural pattern that requires therapeutic intervening to restore the balance and the proper body alignment.